Hello everyone, my name is Jen Nolan and on behalf of Musculoskeletal Australia, I'd like to warmly welcome you to our webinar this evening on the topic of staying strong and on your feet into older age. I'd like to begin by acknowledging the traditional custodians of the land from which we are broadcasting this evening and pay my respects to their elders, past, present and emerging. We're coming to the end of our 2020 series of consumer webinars as we have our last webinar for the year on Wednesday, the 25th of November on the topic of lupus. If you haven't already registered, please do so. Also, if you have missed any of our previous webinars, you can view the recordings on our website. We're also close to finalising our series of webinars for 2021 and we'll inform you of them soon. When you visit our website, you will find a range of extensive information, films and videos, apart from other initiatives and services such as our peer support groups, our MSK Kids program, our MSK Helpline, and our Active Neighbourhoods for Older Australians project, among many other things. Remember to contact our national MSK Helpline at any time via email or phone on 1800 263 265. Our presenter for this evening is Associate Professor Frances Batchelor. Frances is Principal Research Fellow and Director of Clinical Gerontology at the National Ageing Research Institute. She has over 30 years' experience as a clinical physiotherapist and completed her PhD in 2020. Frances's doctoral work focused on falls prevention after stroke. Her current research interests are falls prevention, balance and gait assessment and management, physical activity, the role of technology in ageing, and health and aged care practice. Frances's career is focused on collaborative approaches to research, policy and practice change to improve the lives of older people. Without further ado, I'll hand proceedings over to Frances. Thanks very much, Frances.
Thanks very much, Jen, for that introduction. I'd also like to acknowledge the people of the Woiwurrung language group on whose lands I am located and pay my respects to their ancestors and elders, past and present. I also acknowledge the traditional custodians and their ancestors of the lands and waters across the many nations of Australia where I conduct my work. So thank you very, very much for the invitation to speak at the webinar, this webinar. I'm in Melbourne, so anything that is a little bit out of the ordinary is really much appreciated. So I wanted to start this presentation by talking about the F word. Now don't worry, I'm not going to start the presentation with a swear word. While I think it's really vital that we adopt a positive approach, so staying strong and fit into older age, and I very much agree with that, there's almost no way around the fact that we do need to talk about the F word. And that word, as you might guess, is fall. As we go through talking about falls prevention, I want you to have a little think about some of these questions that are about to come up on the screen. So keep them in the back of your mind as I'm talking. Is a trip or slip a fall? Is it a fall if you don't hurt yourself? Are falls just an inevitable part of getting older and there's nothing we can do to prevent them? Or is a fall just bad luck? And you might be able to answer these questions now, but I think when we get to the end of the presentation, you'll definitely be able to answer these questions. So we all have an idea in our heads about what a fall is. You know what a fall is, right? But surprisingly for researchers and health professionals, it hasn't been easy to agree on a definition. So up on the slide here, I've got two definitions. One from 2001, which says it's an event which results in a person coming to rest inadvertently on the ground or floor or other lower level. And this specific definition then excludes things like fainting or an overwhelming external force, such as being run into by a bicycle, for example, that knocks you off your feet. The second definition on the screen talks about an unplanned descent to the floor or extension of the floor, so it could be onto a chair or some lower surface with or without injury. And they include all types of falls, whether from physiological reasons, such as a faint, or losing your balance, or environmental reasons. But really, the consensus that we've come to as researchers and as health professionals is that a fall is an unintentional event in which a person comes to rest on the ground, floor, or lower level. So you can see that includes things like rolling out of bed, for example, losing your balance and falling back onto a chair, as well as those falls in which people end up on the ground. Now, sometimes medical professionals like to categorise falls as either mechanical or non-mechanical, and this they often use as a way of differentiating between medical causes of falls, such as problems with your heart rhythm or fainting, differentiating them to non-medical falls like trips and slips, for example. But in reality, it's much more complex than just dividing a type of fall into one or the other. Regardless of how we define a fall, what we need to remember is that when we go back to basics, a fall happens when we can't keep our centre of gravity, which is about the middle of your abdomen, or return our centre of gravity to our base of support. And by that I mean the area that is in contact with the ground or a surface. So in this image, we can't really see where this person's centre of gravity is, but we can see their base of support is very small. So it wouldn't take much for their centre of gravity, so in that area of their pelvis, to move outside of the position of where their feet are. And if they're not able to bring that middle section of the body back over to where the feet are, they will fall, in this case, probably onto the floor. So how common are falls? Well, we know that falls increase as we get older. So overall, for over 65s, about a third or 33% of people will fall in any given year. And this increases so that for over the age of 90, around 50% of people will fall in any given year. Now, these are for people living at home. And this work was done by Campbell in the 1980s. And that's quite old now, but unfortunately, those falls rates have not changed substantially over the years. So there's a lot that needs to be done. So I've talked about falls for the older population, but what about those aged under 65? Well, this study, which was undertaken in America, looked at falls in 3 age groups, those aged 20 to 45, those aged 46 to 65, and the 65 and over cohorts. And what they found when they asked them about falls in the previous 2 years was that 18% of that young cohort fell in the previous 2 years, 21% of the middle-aged group fell, and 35% of the over 65s, which is similar to the figures in that group that I mentioned beforehand. And walking was the most common activity that was being undertaken prior to a fall. And you can see on the slide that the injuries are a little different in those different age groups. So we see more wrist and hand injuries and ankle injuries in the younger group. And as we get older, it becomes less about the wrist, hand and ankle and more about the knees and head. And we know that women experience higher rates of injuries across all ages. Now, in the research, there's been very little focus on younger and middle-aged people. And this is despite the fact that we know balance starts to decline definitely in your mid-40s, but possibly as early as your mid-20s. So I think as a whole preventative strategy, we need to be focusing our areas not just with older people, but in the younger age groups. Statistics I gave you were for people living in the community, but what we see is much higher rates for people living in residential aged care. And you can see the 2 sets of lines, the 2 below and the 2 above. The 2 below are the rates of falls with increasing age for people living at home, and the 2 lines above are the rates of falls for people in residential care. And what this tells us is that the rates of falls in residential aged care are around 2 times higher than for people living at home, which is not really a surprise. You can also see that, again, females have higher rates of care of falls across the board. Now, looking at injury, this graph actually shows how hospitalisations as a result of injury change with different ages as we get older. And the blue line is for males, and the orangey red line shows the females. Now, this includes all injuries that result in hospitalisations. And what you can see is up to the age of about around, my screen's quite small here, having a look, around the age of 59, 60, the rates of hospitalisations due to injury are higher for men. But once we reach the age 60 mark, that reverses and we have more hospitalisations due to injury in women. And this is because younger men have higher rates of transport accidents than women do, but as age increases, we see more injuries related to falls, and specifically in women. So falls are a problem for all of society, but particularly in that older age. Now, often we hear a lot of negativity, a lot of quite bad stories about falls resulting in serious injury. But the reality is that most falls do not result in serious injury. For example, 40% of falls result in some sort of bruising or contusion, 30% in a soft tissue injury, and these add up to more than 100% because you can have more than one type of injury. But what we see is that only 1% of falls result in hip fracture and only 2% result in head injury. So I think it's important to bear that in mind, is that really when we think about falls as something incredibly bad, that really is the minority, and often we just hear the horror stories and we don't see people presenting with a minor injury from a fall as an opportunity to really intervene at that point. One thing I wanted to raise is the issue of falls from ladders, because this has been increasing in Australia over the years. So we're seeing an increase in not only the number of falls and hospitalisations as a result of falls from ladders, but also an increase in injury and deaths, and particularly in those aged 60 and over. And the main cause of death is usually head injury. Someone falls from the ladder and lands on their head. And I wanted to highlight this because there has been, at least in Victoria, some significant messages around taking care when using ladders. And I think it's pertinent for all of us to bear that in mind. So just to sum up, we know that falls increase with increasing age. We know that women fall more than men, and the rate is 1.5 to about 2 times higher, and that women sustain higher rates of injury across the minor, moderate and severe injury categories, but men actually have higher rates of fatal injury. We also know there's a higher prevalence of fear of falling in women, and I'm not going to talk about that today, but that's a really interesting topic perhaps for discussion another time. So what causes a fall? We know that falls are multifactorial. It's not just one thing. And as I mentioned previously, when we bring this back to basics, the fall happens when you can't maintain or return your centre of gravity to your base of support, or when the demands on our postural control exceed our body's capabilities. For example, when tripping when a footpath is uneven. So the answer to this question about what causes a fall is really anything that contributes to interfering with our postural control can be a potential cause of a fall, or as we like to call them, it's a potential falls risk factor. So these are aspects or factors within individuals, but also factors that are external to individuals, such as the environment. And here you can see someone who might have some falls risk factors. The most obvious thing is footwear. Perhaps this person is very experienced in walking or balancing, wearing this footwear, but nonetheless, that would be considered a falls risk factor. We can see that she's balancing on a little ledge, but there doesn't seem to be a great deal of contrast to the pavement that's close by. So this is something that we'd also consider an environmental falls risk factor, where there's not sufficient or good contrast between different heights of objects, such as steps. And we might say she looks quite strong, nice strong leg muscles. So that may, in her case, not be a falls risk factor, but something that's protective against falls. So in the research literature and in clinical experience, that's said that there's over 400 different falls risk factors, and I've listed some of these here and you can read them. So we do know that having a history of fall is also predictive of falling in the future. But we also know there's lots of other aspects, such as medication, the number of medications a person takes and the type, particularly medications such as sedatives and anything that interferes with the normal functioning of the brain. We know that there's a typo there where I haven't included the medical conditions, but we do know medical conditions such as chronic pain, osteoarthritis and other types of arthritis, neurological conditions such as stroke and Parkinson's disease and so on, are all falls risk factors. Balance, obviously, vision problems such as cataracts or things like contrast sensitivity problems. And then there's issues to do with sensation feedback from our skin and joints. All of these things in this list are potential falls risk factors. So let's have a think about what could work to prevent falls. And the answer is kind of simple, but it's complex really to implement. The answer is anything that impacts or changes on these falls risk factors that an individual has. When we think of it like that, most of the falls risk factors can, to some extent, be modified, so be improved, so they pose less of a problem for a person and potentially can reduce their risk of falls, except for one really on this list, which is history of falls. We can't really do much about that. And some of the other things, we can do make changes in some of those other falls risk factors to a greater or lesser extent. So for example, someone who has severe dementia, we may not be able to modify, that aspect of the individual, but we may be able to modify other aspects such as improving their footwear. So you can see there are many opportunities to actually make a difference and change falls risk factors for the better. I wanted to just highlight a number of evidence-based interventions that we know really do work to prevent falls. So first of all, we know that exercise is very effective at preventing falls. Now, it doesn't have to be group exercise. We know that both group and individual exercise is both effective at preventing falls, but you need to have balance and strength incorporated within an exercise program. And balance needs to be challenged to a sufficient level. Now, I'm not saying we need to challenge it to the level of this person on the slide. It needs to be sufficiently challenging for a particular individual's level so that it's just outside the comfort zone of where you can balance easily. What the research has found is that it needs to be of sufficient dosage. So 3+ hours per week is needed for the best effect. And walking alone is not enough for falls prevention. Now, that's not to say that walking isn't a good thing, but when we look at the impact in terms of falls prevention, it's not necessarily enough. Exercise would have to be the most studied intervention in this area, and it's clearly one of the most effective interventions. We've seen that in multiple scientific studies, as well as meta-analyses, which is a particular form of grouping scientific studies together to give us an indication of the effectiveness, like the overall effectiveness and the size of that effect. And this is some really important work done by colleagues in New South Wales, Kathy Sherrington and her group of people, who've really been the trailblazers in the world at looking at the beneficial effects of exercise and the size of that effect. And that's what I'll show you here. Now, you don't need to read every aspect of this table. What I would like you to look at is the left-hand column, which just talks about the type of exercise. And this is this form of analysis where the results of a whole lot of different trials are grouped together so we can estimate the effect on falls. So we'll ignore the first row, but I want you to look at the second row, which is in white. So when we look at studies or trials that examine the impact of gait, balance and functional training, what we see when we group them together, going across to the right-hand column in red, is that leads to a 24% reduction in the rate of falls, which is what we would consider relatively large. If we look at just doing resistance training, so that's weight training or strength training, there's no effect when we group those 5 trials together. With Tai Chi, there's potentially a 19% reduction, but when we look at the overall quality of the trials, we're not 100% certain that 19% is completely accurate. Often we say science, you know, it's an exact science, but what we're dealing often with in research is estimates. And so that's why we're not always 100% certain that we say, yes, it's definitely 19%. But when we look at multiple types of exercise at the bottom, so that's combining gait, balance and functional training along with resistance training, we get a 34% reduction in the rate of falls. So really suggesting that it has to include balance and it has to include function as well as strength training. And we need obviously a lot more studies on things like dance, which, you know, is potentially a very promising intervention, but we just don't have enough evidence at the moment to say that it's completely effective. So some of the most effective exercise programs, one is known as the Otago exercise program, and that's normally delivered by a health professional. Now, as with all of the things I'm talking about today, this isn't individual advice. I would obviously encourage you to talk to a health professional or your doctor. This is really just general information. So the Otago exercise program is probably the most studied and researched exercise program in the world, and it's been shown to be very effective. It's very structured. It includes strength and balance training, and it's done in the home but guided by a health professional. And it's most effective for, I guess, older people or people who are a little bit more frail because it's targeted at a lower level of function. Whereas, and that one was developed in New Zealand and the resources are freely available online. The LIFE program, which stands for Lifestyle Integrated Functional Exercise Program, also needs to be delivered by a trainer, and that is a program that incorporates incidental activity into your everyday life. That one is not freely accessible. It's predominantly implemented in New South Wales, but again, highly effective in reducing falls. So there are a number of other exercise programs out there, but these are just 2 examples. So the second thing that's been shown to be effective is medication review. So what we know to work is that you should reduce the number of medications where possible. And again, this is done in conjunction with a general practitioner and a pharmacist. It's important to have your medications reviewed and also avoid the use of sleeping tablets, anti-anxiety tablets. And as mentioned, any tablets that impact on brain or make you drowsy. And so really we know that that gradual withdrawal does seem to impact on reducing the rate of falls, but not necessarily whether you have one fall, but whether you have frequent falls. It seems to stop the number of falls per person. So the third thing that the evidence tells us, and there's a little bit of a mixed picture here, is around eye health. So just having your vision checked and being given advice and the right glasses doesn't necessarily mean that that will change your falls rate. And in fact, one study found that assessments and an eye examination and new glasses did lead to increased falls. So we need to have some caution there. And that's probably because, you know, when you get some new glasses, there's an adjustment period, or perhaps the people who got their new glasses were a lot more active, and so that led to being exposed to more risk and then further falls. But we do know that cataract surgery, particularly on the first eye, is effective for women, particularly for women on the rate of falls. And I've just included a little image there, which is from Vision Australia, and it's blurred because that's how cataracts, you know, the world appears to a person who has cataracts. The other thing that the research has shown is that for people who are active and out and about, so walking up and down curbs and steps, multifocals are probably increasing the risk of falls, and it's better to just have single vision lenses for those who are active and outdoors and don't have any cognitive, you know, problems. Whereas for people who are predominantly indoors, perhaps in residential aged care, who may have some issues with cognition and thinking, they're better off with their multifocals and not having to think about swapping glasses in between situations. I've just included some quotes from a Cochrane review, which is really, the Cochrane reviews are really a very rigorous approach to looking at all the evidence that's out there and then making recommendations. And so the last one on falls prevention in the community was done in 2012. We're due for a new one, but you can see what they're suggesting in that Cochrane review. So 2 more. Home safety is really important. So removing things like rugs, having the appropriate supports when you need them, and all of the research really relates to that home environment rather than environments outside the home. So we do know that if you remove hazards, it will reduce the risk of falls, but that really needs to be done by a professional such as an occupational therapist. And it works best for those at high risk. So the people who maybe have come out of hospital and not as good as on their feet as they previously were. One aspect though, and some work has been done to look at this, is really the uptake and adherence to some of the recommendations. So for example, an occupational therapist might suggest that you remove some rugs if they seem to be a hazard, but when an assessor went back at a later stage, it wasn't surprising that the rug had returned to its original space. So I think that environmental hazard reduction really needs to be undertaken very much with the person at the centre of their care, with them, you know, in a dialogue rather than just a recommendation from an allied health professional to say, you know, do this, do that. Really needs to be a conversation about what's going to work best for the person concerned. So the last one I wanted to touch on was vitamin D. Now, there's a lot of talk about vitamin D, and it's a little bit unclear about how effective vitamin D is in falls and injury prevention. Vitamin D does potentially have a role in falls prevention because it also impacts on on muscle strength as well as bone. So it's not just about the bones, but potentially can help with muscle strength, which also then, if we're stronger, we're less likely to fall. But it's complex because there's different types of vitamin D. There are different dosages around there, different laboratories say that a certain level is deficient in vitamin D. There's not consensus around what deficiency is. Some studies look at supplementation with calcium and some without. We're doing, not we personally, but studies have been done and they look at fractures as well as falls. And one study even showed an increase in falls and fractures with a large yearly dose. So the conclusion is that probably taking vitamin D supplements with or without calcium doesn't reduce falls, but it might in people who have lower level vitamin D in the blood at the start of a trial. But again, this is the impact on falls, and not necessarily, it doesn't necessarily mean vitamin D shouldn't be taken. That needs a conversation with your doctor. So I've talked a bit about what the evidence shows does work. I think, as I've mentioned, we haven't seen a huge change actually in falls rates. So what some of the future work is looking at is injury prevention. So training people to fall without injuring themselves. But there's a lot of technology out there now. So there's airbags that inflate when a person is not quite on the ground, but close to its sensors, when someone has lost their balance, and then inflates in a similar way to an airbag in a car. And these are commercially available, but don't necessarily have, really good quality evidence about their effectiveness, even though the manufacturers might claim effectiveness. What we're seeing is a lot of new studies looking at reactive step training, so voluntary step training, so really increasing reaction time, decreasing reaction time and increasing the speed of response. And there's a lot of work in exergames and using mind-body virtual reality. Many research groups are looking at how we can prevent falls by training dual task activities. So doing things like talking when you're walking. We now see a lot of people obviously using their phones when they're walking. So is that something that we specifically need people to practice doing? A lot around technology and wearables, but again, most of these are focused on detecting falls and alerting people when a fall has occurred rather than falls prevention. And some residential aged care facilities are looking at things like smart floors, but again, mainly focused on fall detection. So I think part of the reason that we haven't seen those reductions in falls that we'd really like to see is that we have gaps in our knowledge and in the implementation of what we know works. So in that prevention space, we haven't seen a lot of research looking at culturally and linguistically diverse communities, and I think that really needs to be addressed as a matter of urgency. In some particular groups, we haven't seen effective falls prevention interventions. There are some trials in progress there, but I know with my own research, when I did my PhD, we did a large, very robust trial of falls prevention in people with stroke, and it didn't work. So I think we need to come up with some more innovative methods to look at those cohorts. And there's surprisingly little research on effectiveness for people living with conditions such as acute and chronic pain, osteoarthritis, back pain, and similar conditions. And what we haven't really seen is the translation of evidence into practice to achieve change at a population level. And I think what we need to do is consider a life course approach. So mostly people have looked at interventions that are focused on the right-hand side of these two little graphs. In those people that may have already had a fall or they've had recurrent falls, and then they seek health professional advice. But I think what we really need to do is focus on younger age and middle age. Maybe we need to start thinking about improving and working on balance in our 20s, 30s, 40s and beyond. And I know often we talk about building a bone bank to, prevent osteoporosis, but I think we also can we can try and build a balance bank. I've included in here, and so anyone who looks at the recording of this webinar, feel free to follow up with some of these resources. So the first one is a website that I've been working on in conjunction with physiotherapists around Australia. And it has resources for older people, including tips for exercising at 3 different levels, and as well as tips for falls prevention and tips for those who are staying at home due to COVID restrictions. But there are also a number of other really good resources that I would suggest that you follow up with. So finally, I wanted to say, I think we really should embrace the F word, the falls word. Falls are not something really to be ashamed of. They can be prevented, and we can do things about them. And it's really vital that, you know, we don't hide away from them, because the fall is an opportunity to, you know, not that we want people to fall, but it's an opportunity that people can make changes to improve, to prevent falls in the future, but also to have other positive health outcomes. So thinking back to the questions I posed at the start, a trip or a slip is a fall. So when I hear people saying, oh, I didn't really fall over, it was just a trip, you know, the path was uneven, so I wouldn't have fallen over. No, that still is a fall, and you really should seek health professional advice. But falls are not inevitable, and they're not an inevitable part of aging. And we know that many falls can be prevented. Now, if there's one, well, I think also sometimes falls can just be bad luck. Sometimes the environment and, you know, perhaps the things on the day don't really align, and, you know, we can experience bad luck. But the one key message I want to give to you today, if you take away one thing, is to think about exercise. Exercise is the key, but it needs to challenge both balance and strength. With that, I would like to say thank you very much for listening. And
thanks very much, Frances. One thing I love about all these webinars is I get to learn quite a lot of information that's sort of relevant also to me as I age and so on. So that's really great. And I think a key message there, which I really thought was fantastic, was that, you know, in a way you said an early fall or a fall at any time is really an opportunity to then undertake you know, to get some help, or to think about those falls risk factors you identified and so on. So I think rather than sort of perceiving it in a negative light, a fall can be an opportunity to sort of see what can be done to address any issues and so on. We do have a question, and it's certainly one thing that came to my mind. Why is it that women have a higher number of falls across all age groups?
That's a fantastic question. We don't really know the answer to that. We know why they have higher rates of injury, obviously because of bone density issues. And we think maybe there's something to do with strength and balance, but it's really something that we haven't been able to unravel. So yeah, it's one of those mysteries of research.
Okay, maybe they talk about their falls more often than men do.
Maybe they do. I think it's a bit alarming that men have higher rates of fatal falls too. So maybe things with men, maybe they're not seeking out health professional advice, maybe only even at a much later stage. And then, you know, when things are quite bad, there's a very serious injury.
Yes, I mean, given that we know that often men will sort of be less likely to seek medical assistance and so on, or see a doctor, you know, I base my comment on that. Someone has also asked, can exercising in water, like water aerobics, be beneficial for preventing a fall as part of that sort of exercise you're recommending?
Yeah, so the answer to that in relation to falls is it's probably not beneficial, but that's not to say you shouldn't do it. So, I mean, we know that exercising in water is a fabulous type of exercise for so many other things. So I would suggest keep up the exercise in water, but add in some exercise that's on land as well to challenge your balance. So yeah, good question.
Someone's asked why are ladder injuries increasing? Is there any thoughts as to why we're seeing an increase in ladder injuries?
I think it's because we do have an ageing population and we've got people staying at home for longer. And so with that comes things like, doing the things that you've previously done and maybe not modifying your behaviour. So I think it's really to do with the ageing of the population and that profile of staying at home for longer.
Someone has sort of said where they live in southwestern Victoria, there seems to be a long waiting list for many programs, and there's only one place in the sort of local area that actually offers a balance course. Any suggestions, Frances, as to where people might find out? Is it a matter of sort of searching the local area to see what might be available?
I think you could do that, but yeah, it's definitely a problem for regional and remote areas. Perhaps you could have a look at the Safe Exercise at Home website that has got some links to some online, courses and exercise programs that you could do. And it's also got a lot of safety information as well about exercising safely when you're on your own and you don't have a health professional right in front of you, or a trainer or a group leader.
And someone, good point, what should you do if you fall over and you can't get up and you don't have one of those sort of emergency buttons to press?
Yeah, so the first thing we always recommend if you fall over and can't get up, just take a moment and see whether you've got any injuries. Don't try and rush and try and get yourself up. Depends where it is. If it's at home, sometimes you can get yourself to somewhere stable that can assist you to get to the next level, like onto a chair. But obviously, if you're out and about, you'll need to ask for assistance of someone else. If you're at home and you have a mobile phone with you and you can't get up, then obviously call the ambulance. But some of the programs that researchers and others have been working on are also looking at actually training people to get off the floor, on and off the floor. And I think it's something we should do as we get older, is maintain that function. Often we lose it. It gets harder and harder to get onto the floor. So yeah, I think if you can do it, keep doing it.
Yeah, no, that's a good suggestion to even practice if you're concerned about such a thing. Someone asks, would you suggest that decluttering to prevent falls would be a good idea?
Yes, any clutter around the house obviously is a hazard in terms of tripping. Sometimes that clutter are small animals, such as our pets, can get in the way, and we're not recommending get rid of your pets. They're vital for your mental health and well-being. But thinking about having even and clear surfaces, particularly on the floor. And I'm just looking at my home office setup here, and I've got cords all over the floor, so I'm kind of not doing what I'm supposed to do. But really seeing whether you can keep those cords separate, you can keep the areas clear so you've got circulation space. And, a little bit of that is better than nothing.
That's right. And someone's asked, does taking the pet dog for a walk increase the likelihood of falls in both males and females?
Don't think there's been a study exactly looking at that, and I guess it depends on the dog, doesn't it? Some of us, as we age, we have an aging dog as well, but some of us don't. If your dog's particularly vigorous and, dragging you along and that's beyond your capacity to balance, then that could be a problem. But also, getting out and about with your dog helps your fitness. So I think it's really just weighing up, what's your capabilities and how is that matched to the particular type of dog that you're taking for a walk.
And someone has asked about the benefit of Nordic walking. So you mentioned before that there's not enough evidence to indicate, or that walking doesn't provide a lot of particular benefit in relation to falls prevention. If you're familiar, Frances, with Nordic walking, which is also using the arms and so on, any comment on that?
It's a fabulous type of exercise, and again, because I'm looking at falls, it's not necessarily going to prevent the falls, but it's fabulous exercise, and it's also fabulous for people who may have a little bit of balance problems, and they get that extra stability from the poles at the same time as really getting that vigorous exercise that we should have. We all should be getting about 30 minutes of vigorous, moderately vigorous physical activity, preferably on each day. That's our physical activity guidelines.
And someone has asked about putting up the exercises you had up before, but for that person, for Lois, we will be providing the recording of this webinar to everyone. So when you're viewing the recording, you can actually stop it wherever you like along the way if you want to sort of take particular note of anything. So I won't get Frances to go back now. Another question, does the person's walking pace have any impact on their likelihood of a fall or otherwise?
Fantastic question. So we do know that people who are walking naturally slower are probably at increased risk of falls. But when we look at walking in a research sense, what we're looking at is symmetry in walking. So where we see higher falls risk is people who, the foot placement isn't even and symmetrical, and it's all a bit all over the place. So yes, walking speed and symmetry does have quite a bit to do with falls.
And just a question I had before, Frances, was you talked about the gait, balance and functional or task training. What do you mean by functional or task training? Is that like the example you mentioned of like practicing walking, speaking on a mobile phone? Is that like a functional task?
Yeah. So all of those things that we do as tasks in our normal daily life. So it might be stepping up and down a curb. It could be negotiating around obstacles, carrying something, picking something up off the floor, turning to look at something, walking. One thing that can be particularly challenging is walking in a crowd for some people. When you've got, people coming towards you, and if you've got a little bit of problems with your vestibular system, your inner ear system that's responsible for balance, that can be quite confronting. So when we talk about tasks, it's that gradual exposure to those kind of everyday activities. I think for those of us in lockdown, in restrictions, we haven't necessarily been going out and about in shopping centres, for example, and that's going to take some getting used to as well, and gradually re-entering into those normal tasks that we're used to.
So Frances, would you suggest that people sort of practice those functional tasks only when they're aware of a problem, but in anticipation of a potential problem, as if they feel like their balance is maybe not as good as it used to be?
Yeah. So we know that if you think your balance is not as good as it used to be, then you probably do have a mild balance problem. And so we would always say, obviously, prevention is better than cure. So even addressing things, looking for exercise groups, even when you think, oh, maybe I'm just not as good as I used to be, I think is a really good time to start. Don't wait till it's too late.
Oh, and someone's asked about, is there such a thing as walking etiquette? Example, keeping to the left. I would have thought there, I don't know, it's not spelt out, but I would think that there is. What your comment on that?
Yes, well, there is definitely walking etiquette. As anyone who's gone to Europe, I lived in Germany for a while, and I think for the first, couple of weeks that I was there, I was walking to the left, but they do the other side. So you kept going to bump into each other. So I think there's definitely walking etiquette. Also in this time, try to keep your distance, so 1.5 meters apart. The other thing just on that, we know that wearing masks can impede your peripheral vision, the lower vision, because it's covering that lower part of your visual field. So what we say there is wear your mask up, but look down. You need to look down frequently when you're walking with a mask, or when you're approaching a curb, or a curb going up or down.
I think that's very true. I think that the masks certainly do change your vision.
Perception,
and yeah, absolutely. That's a very good point. If anyone's got any last questions or whatever, please pop them in the question box now. I mean, we've had lots of good questions, I think, very practical questions, which is really good. And you know, people have the opportunity to ask things that have been potentially on their minds and so on. With regards to the last question from me, when you sort of say that balance starts to decline in, you know, when people are in their mid-40s, do you know of many programs? Is there a bit of an awareness these days? Is there more effort to actually inform people in their 40s that they should start thinking about balance?
I think there's next to no awareness of this issue. And it's something we've talked a lot about at the National Ageing Research Institute. What we'd like to see is kind of a campaign, a national campaign, to highlight, you know, balance as something that needs to be addressed. You know, it's not just about walking, it's not just about getting your 30 minutes, but it's about staying on your feet and preventing that decline. But we need money to do that, and as we know, that's often a sticking point.
Yeah, no, it's really interesting information to think about that. You know, often it is just perceived as something that applies to people in a much older age group. But you know, that's certainly, I'm sure a lot of people are not aware of that. So that's very interesting information. Well, Frances, there's no further questions this evening. So on behalf of everyone who's joined, on behalf of Musculoskeletal Australia, thank you very much for a very important presentation, and one that probably doesn't get as much sort of, you know, community awareness and publicity as it should, because it's just such an important topic. So thank you so much for your presentation this evening. It's been very informative. I'd like to thank everyone who's joined us this evening. As you said before, the presentation will be available on our website next week, and everyone who registered for the webinar will be receiving it, will be emailed the link to that to our website as well. So on that note, don't forget our lupus webinar towards the end of November. That's on our website at the moment. I'd like to thank Frances once again, and also thank NARI, your organisation, and wish you well, and wish everyone else well, and hopefully we'll see you again in November.